So I'm Jess Ackerman. I'm a nurse practitioner here at Queens Geriatric's outpatient clinic. Our clinic is in POB 3. I've been at Queens, like I was telling Bill, for I think more like 8 years. But he had asked me to do some education on geriatrics because of this event coming up this week. This week? Next week?
It starts officially Sunday.
Okay. So big event, quite an honor, I guess. And so I wanted to just kind of switch gears because I know a lot of the staff are acute care trained, but geriatrics is unique in such that your acute care experience is going to be huge, but taking care of an elderly person is a unique thing. So I wanted to just be very practical with this presentation and give you some key components that I hope will help, and not going to try to be super technical or anything, but just starting off. Here we go. So what is geriatrics? Pretty easy medical practice that addresses the complex needs of older patients. When we say older patients, we think 65 and older, but really a geriatric could be a patient who's 50 or 55 if they're physiologically older. So what we do in Geri is really maintain functional independence and despite chronic disease. So that is kind of the goal of our practice. It is always multidisciplinary. It's very emotionally fulfilling, and it's equally challenging. And geriatric providers are patient people, I'd say, and have to have a lot of compassion. So why does it matter to any healthcare provider, really? Because we're going to see more and more geriatrics, period, bottom line. And the more that we can understand how geriatrics are, the better we can take care of them. So, unique, I say, that this population is, first of all, they present atypically with very, very vague symptoms. For example, with UTIs, falling is one of the most common presentations of a UTI. They exhibit functional decline for many reasons. Maybe they can't drive anymore because their vision, they have poor cognition, musculoskeletal issues, stenosis, arthritis. They can't turn, look, they can't react as quickly. They're also unique in that symptoms can be misleading. So someone comes in for, they're agitated, but really they're just constipated. And a lot of the signs can obscure another. So, say they have osteoporosis, they've had compression fractures, they're having low back pain, but really they're having a UTI or, again, something like constipation. Sometimes they don't present at all. So keep that in mind as well. I kind of wanted to be able to focus this talk with the syndromes that we see in geriatrics, because I think, and I'll list them and I'll kind of make detail on the ones I think are more pertinent to you. But the syndromes themselves are broad categories of signs and symptoms that we see commonly in geriatrics, and they're multifactorial. One is there's normal changes in aging. Two, there are multiple diagnoses. They're on tons of medications. They see a lot of different providers. And adverse effects of therapeutic interventions, a lot of times medications. So now I'm going to list the syndromes. So this is a mnemonic for it. Spices with 2 P's and 2 C's. First one being sleep problems. That's a big one. And it's actually a really hard one to treat. Problems with eating or feeding, pain, of course. Incontinence is a big issue. Confusion with the 3 Ds, dementia, delirium, depression, constipation, another huge one. Evidence of falls and skin breakdown. So the ones in the red, I'll go into more detail about. And I didn't pick falls because, one, I didn't have that much time, but two, I think that you'll be able to triage a fall pretty well with your experience. So with sleep, there's some normal aging changes we have with sleep. We don't need more sleep. Geriatrics don't need more sleep in a 24-hour period, but they get decreased quality of nighttime sleep. So, they're taking more daytime naps. They're less tolerant to the sleep-wake cycle, and traveling especially is going to be key on that. And a lot of these recipients will be traveling, right? Most of them. So, and I kind of will mention traveling amongst all of the syndromes. So, another reason for poor sleep, environmental changes, again, also big with traveling. They're in a new environment, they're in accommodations, they may have a bad mattress and a bad back anyway, noise, temperature, maybe their partner is a snorer or sleep apnea. So keep those in mind. There's several medications that can contribute to sleep. Antidepressants actually can cause insomnia themselves. Caffeine, of course, and if you have elderly who are drinking coffee all day, one, it's a diuretic and a stimulant, so that's probably going to lead to poor sleep. Diuretics themselves, a lot of them are on for cardiac conditions, and over-the-counter meds. So these are interesting because, elderly think, oh, they're over-the-counter, they're safe. No worries, but a lot of the cold medications that have the phenylephrine or pseudoephedrine, which pseudoephedrine is a lot harder to find now, but still, and diphenhydramine or Benadryl, those can cause poor sleep. They're excitability drugs. So, and Benadryl I'll talk more about too with later. So, and then the diseases themselves that contribute to sleep disorders, BPH, overactive bladder, heart failure, if you're having orthopnea, GERD, reflux, COPD, restless leg, sleep apnea, anxiety, depression, dementia, and pain. So, any questions so far? No.
You said you were going to talk a little more about diphenhydramine.
Mm-hmm.
Is it a safe assumption that in our general acute practice that we're going to see other drugs besides diphenhydramine that have a paradoxical reaction? Diphenhydramine, usually
being the most common, yeah.
Okay, so.
Yeah, that's the biggest one, because a lot of the over-the-counter preparations, whatever, if they're antihistamines or cold medicines, they're going to have that in them. And a lot of the, nighttime sleep aids, that's how they're putting these elderly to sleep. So yeah, it can have a paradoxical effect for sure. But they're anticholinergics too, as you'll see. So dry mouth, constipation, confusion, those are all. And then they get more tolerance to those as they go on too. But so eventually, poor sleep can lead to all of these things. Disorientation, confusion, cognitive impairment, especially if they already have a dementia at baseline, forgetfulness, falls, wandering, restlessness, depression, sundowning we talk about with dementias. Then they're going to, if they're having poor sleep, they're going to try to self-medicate for poor sleep. So using those meds that I talked about earlier. So I just kind of put tips with each syndrome for sleep problems. Watch for prescribed sleep aids, benzos, hypnotic, narcotics. Benzos in the elderly, that's like the #1 beer criteria list item. Just not a good idea. And a lot of these geriatrics aren't seeing geriatricians, so their primary care doctors are internists and not maybe as aware of geriatric issues so much. So oh, you can't sleep, oh, let's try Xanax. Just not good. So And then the hypnotics are, you know, your Ambiens and Lunestas and, you know, those sleep medications. But, you know, increased drowsiness for daytime, a lot of falls on this medications. And then if you're mixing it with alcohol, you get an even a poorer outcome. So, and then again, the self-prescribed over-the-counter sleep aids. The first-generation antihistamines are highly cholinergic, as I mentioned earlier. Greater risk for confusion, dry mouth, constipation, falls. So the biggest one, diphenhydramine, and then chlorpheniramine is Alercor, and doxylamine. But diphenhydramine is the biggest one, I'd say. And then there's over-the-counter sleep aids, melatonin, valerian root, kava kava, St. John's wort. You know, these, you know, we use melatonin a lot, actually. Valerian root can have a little bit more sedating and next day drowsiness effect. Kava kava, I doubt, you know, mainland elderly will know about or be on. And then St. John's wort, you know, interacts with a lot of anticoagulants. So, you know, be cautious with that. And then, you know, avoiding stimulants before lunch or, you know, especially at nighttime, your coffees. So incontinence is the next one I wanted to touch on. So there's the different types, not super important. It is important to know that incontinence itself causes a lot of stress for these patients. They don't want to leave the home, so they stay home and they get depressed about it. So there's a lot of quality of life issues with that. There's numerous reasons for it on the side there. I don't have to list them. You can read them, but let me move on. So in having elderly who have and incontinence, by the way, is not normal aging. It is considered abnormal aging, but it's common nonetheless. So this is a really good point to know. Elderly, bottom line, they don't like to drink because if they're incontinent, they don't want to have accidents. 2, it's inconvenient, especially if these are recipients coming from abroad and don't know where the bathrooms are, and it kind of causes some anxiety. And naturally, there's a decreased need to drink, decreased need, thirst reflex or sensation, I guess. So, you know, if the staff can know where the bathrooms are and telling the recipients right from the get-go, you know, I recommend scheduling like bathroom breaks every couple hours, drinks throughout the day. You know, they'll drink more if they know where the bathrooms are. And I thought of, like, you know, maybe, I don't know how much you're in charge of the activities, but giving them some water and saying, you know, why don't you drink this before noon, so that you're ensuring that they're getting some good PO fluids. And I don't know if you would stock like some spare pads, or it depends. So yeah. So and then also, you know, maybe counseling them, you know, don't drink so much at night, especially alcohol, and trying to making up for it during the day. And then bladder irritants, caffeine, alcohol, and nicotine. And then preventing constipation is a big one. That's a whole nother topic. So dementia, when I say the 3Ds, so confusion was part of the spices, and so dementia, delirium, depression are the big components of that. So dementia in and of itself is a non-reversible mental disorder, and you get slow loss of intellectual abilities that interfere with the functioning, and that's a big part of this. And this is a very, very underdiagnosed problem, especially if, and this is what we probably get consulted for most. So you see first initially a memory loss of your short term, and then later of the long term. You see personality changes, the 3 A's, you know, you can't recognize things you used to recognize, you can't carry out functions you used to do, you can't speak how you used to, you can't problem solve, or this executive thinking kind of decreases. You're at much higher risk for delirium when you have an underlying dementia, and behavior changes are huge. So, hallucinations, delusions, paranoia, sexually inappropriateness. So, and I think it's safe to say, if people are changing their environment so drastically and they're already at risk for these, what if you see their first break of a dementia on this trip, So just kind of be mindful of that. So tips for this, these guys like routine, almost like young children, they need routine. So again, traveling in unfamiliar surroundings may exacerbate these symptoms. We use a lot of safe return bracelets for our patients, especially one's history of wandering. So if you see a ID or safe return bracelet, you'd probably know, bless you, that they do have an underlying dementia. Hopefully they're with caregivers. I think a lot of the families will be joining them. And these are the meds we use a lot for dementia. So if you see this on a med list, then you'll know pretty much right away that this could be the underlying cause.
Let me interject.
Sure.
So we know that what we're actually providing them during this conference is going to be problematic in terms of dementia.
Mm-hmm.
The lack of routine, or their routine,
right.
Introduction of multiple things.
Right.
So in light of that, is there anything we can do in maintaining that routine that we have established, or anything that might be helpful in this sort of chaotic time for them?
Yes.
Might sort of allow them to not go into that problem.
Orienting them frequently is huge. Kind of, if possible, allotting them more time to get their bearings. Talking with the families or caregivers who are with them, and maybe educating the caregivers on what to expect. Let me think of what else. It may be, like you said, a little bit chaotic. So I think, the demographic that you mentioned, 70-year-olds, pretty high functioning. Even though they're functioning now, it doesn't mean that there couldn't be a baseline dementia for sure. So I can't think of too many others, except for just being very systematic in your approach to anything new for them. And, if they're advanced, they're not going to be able to process that information, but their caregivers will, and their caregivers know them so well that they'll best know how to deal with it. So a lot of what we do in geriatrics, we treat the patient, but the caregiver is really also the patient. So yep. So delirium, this is a acute change, so abrupt impairment of global cognitive functioning, acute confusion, and encephalopathy. And this, unlike dementia, is reversible. So if you're seeing a huge change in baseline and mental status, one, that's an ER visit, but two, this is, more of a delirium, we hope. So this is a mnemonic delirium, easy to remember. When we see a delirious person, we think about, drug use. Is there electrolyte abnormality? Think of drugs. Are they withdrawing from a certain drug? Are they not getting their pain medication? Are they getting too much pain medication? Infection's a big one. Reduced sensory input, intracranial events, urinary incontinence or fecal impaction, and MIs is the last one. So when you're traveling, for these guys, just any change in mental status, like I said, just keep an eye out. I think usually meds and infection are the two most common culprits. And again, any change in mental status is a medical emergency. Hopefully these recipients will have med lists on them, so if something's going wrong, or I don't know if you assess those med lists just routinely or only if something's happened.
Provided it was a voluntary thing. So
Awesome.
You can't force them to disclose their medical.
Right.
But many of them have provided, at least in part, some of their history and
Good.
medication. So
That's very, very helpful. Yeah.
first thing
not drinking, just change in routine. Keep them moving around, keep them drinking, increase their roughage, and then there's always over-the-counter stool softeners and laxatives. But be cautious with those. They can be overused for sure. And constipation, if you haven't had a BM in one day, it's not truly constipation. But sometimes it presents that way. It's very, totally. So, and it's almost a medical emergency to some of our older patients. So, kind of just adding in general, Hawaii's hot and humid, obviously, and I think a lot of the recipients will not be used to this climate. They're probably going to be more active than normal, I would assume, with the whole week of events. Likely drinking less, having all these medications that they're normally on, and being elderly in and of itself. Recipe for dehydration, orthostasis, electrolyte imbalances, fatigue, falls, behavior changes, commonly underdiagnosed problems in our elderly, substance abuse, so and mostly alcoholism. So I don't know if this event they may be drinking more, or maybe they're drinking less. So withdrawal, we want to look for benzos, abuse, opioids, and then also very underdiagnosed is dementia and depression. So. And then as we're traveling, things to think of, DVTs and PEs, just for being on the plane, and then, ID, respiratory and GI issues. So anything can happen. I mean, I'm sure you know. And I just wanted to mention, at the end, advanced planning. I don't know if you know what a pulse is. I'm sure you do if you're a medical, emergency responder. So it's in Hawaii, it's this beautiful bright green form. And one of my personal goals in the clinic is to have every patient at least have a pulse. Do they have one? And second, where is it? Is it visible? And does the family know what it says, or the caregiver, so that everyone's kind of on the same page? And then advanced healthcare directive, that's my secondary goal. It's a little bit more involved, but is there a DPOA, and does that DPOA know the patient's wishes? Where's the DPA? How do we get a hold of them? And where is the document itself? And is it notarized, or is it completed? So, I think.
And then,
so
that we know, I think I know, but DPOA, for those that may not know, it designated person of authority.
Yeah.
And then the AHCH is the advanced.
Right.
So.
Correct. Yep. Or a durable power of attorney, same thing, advanced healthcare directive. Yeah. So that's pretty much all I had. In a nutshell, I could do.